Thank you. And we actually do have another email. A person named Michael, who describes himself as a fairly new ethics consultant, is asking whether during this process your goal is to stay neutral among the parties, and if that's the goal, do you struggle with that because perhaps one of the parties is starting to make more sense or sort of gain some of our allegiance, and we want to side with them?
I think that is a very good question, and it's important to recognize when you hear the initial facts and the initial ethical issues stated in the case, just as John was saying, sometimes we get that little bit of anxiety or the flutter because you are thinking, okay, I might have a view about what I think this case is about and the direction that it should go if it was my choice, but it's not my choice. And that's not my role. My role is to try to remain as a facilitator. It doesn't mean that you don't have a perspective, and it doesn't mean, as Kayhan was saying, you're saying any option is an acceptable option, because that's not true. But as far as your reaction and response to the other human beings in the room, inevitably you're going to have some that you like and some that you find more challenging. I think it's important to recognize that up front as that's happening and kind of check yourself, because you are only seeing a tiny slice of all of the family dynamics, the team dynamics, the emotions, the challenges that they're all facing, and you can never fully know what's happening and what it's like to walk in their shoes. So I think compassion and empathy is a huge piece of it. Sometimes there are people that are much more challenging to deal with, and you sense yourself saying, oh, this son or this daughter is a little bit more rational or a little bit more reasonable. We hear these terms all the time. Or the opposite, this person is really a challenging patient or a difficult family member. And so I know personally I try to take that with a grain of salt and put that to the side, even if somebody says that to me before I meet these people. And then if you do feel yourself having those kind of reactions, you have to remind yourself that you don't know the full story and you don't know what brought that person to that place where they're exhibiting those behaviors. And that hopefully can help kind of keep that in check and help you remain as neutral as you can. There is no such thing as pure neutrality, but as neutral as you can.
That's nicely said, Katie. You know, one thing that I'm reminded of as you say that is these are oftentimes irrational times in these people's lives, right? They're working under extraordinary stress usually. They're oftentimes dealing with the potential loss of a loved one. So our expectation of reason and our being drawn to reason, while natural and understandable, is an important one to check, as you note. I also try to attend to my sense of what a family needs. So I work in an ethics consultation to make sure that I'm not sitting in the room with the nurses and a couple doctors when the family enters the room. I'd much rather be out in the hallway and greet them in the hallway and walk in with them so that I'm not perceived as one more person on the other side of that table that they're going to have to deal with. If I really want to be a facilitator, I want to try to quickly establish some trust with them and let them know that I really do want to hear what they're saying. I think another resource on the neutrality front is chaplaincy. If you have resources to a good chaplain, let the chaplain play the role of the patient or family advocate so that they don't feel alone in that room. Have the chaplain there with them so that they feel supported and that they know that they have someone there who's simply concerned with their personal well-being. And that, I think, can free the ethicist up a little bit to work as the facilitator in that conversation.
That's a great point, because I think from the family's perspective, they may not understand what our role is. And if we explain that our role is a mediative role, we're there to mediate these differences or facilitate these differences, they may feel like, well, you may be aligned with the interests of the hospital because you're paid by the hospital. Yep. And I think your point is very well taken, that if they feel like they're getting support from a chaplain or some kind of patient relations representative or someone in the hospital who can be truly their advocate. Because I think that's one of our challenges, is that we want to be there for our patients, but I think to view ourselves as purely a patient advocate is probably a misnomer, a misapplication of what our role really is, which I think is to facilitate and to understand that everyone has a stake, the team members, the patient, the family members. I mean, ultimately we want to protect the rights of that patient. So I think it's a very well taken point that we want to make sure that the patient's family feels supported, but that our role may not lend itself as easily as some other healthcare professionals.
And so would a case like this typically resolve then in one side or the other more or less getting what they had hoped for, meaning either the physician gets his 5 days or the family gets to stop life-extending care and switch to palliative care? Or typically do you negotiate something in between? What happens here?
Sometimes what happens is you have an ethics consultation and everyone gets into the room, and as we've described, different parties and different stakeholders have the opportunity to express what their concerns are and their moral dilemmas. And sometimes you're able in that meeting, say it might be an hour, it might be 2. I had one recently that was 2 hours or longer, and people are able to come to some agreement and say, yes, we believe this is what my mother would want. So Patty and Peter in this case might have been able to come to an agreement and say, yes, okay, our mother would have wanted this, so that's what we're going to say as her representatives. Other times, family members sometimes need a little time to process all of that information, as well as the ethical options that are spelled out for them. And they may need to speak to other family members, so they may not want to make that decision solely on their own, or just the 2 of them, and they may need some private time to discuss what their mother would have wanted. And so often you might say, okay, let's meet again tomorrow, or let's touch base tomorrow morning, or in 24 hours, and find out where you are as a family. I've had that happen multiple times where people aren't able to right in that meeting say what they would choose for their loved one, but they're able to say, give us a day to process and talk to some other people in the family, and we'll be able to tell you tomorrow. Sometimes it takes more than one even ethics consultation. You might have them, if it's an ongoing case and it stretches out, you might meet every couple of days or in 2 days, particularly if the patient's condition changes or some other medically relevant fact comes to light. Or sometimes you're waiting for somebody to come from out of town to help make those decisions. So most of the time I think you can come to some at least steps that are going to happen after the meeting. Sometimes you have to wait a day or so for the family to process those things.
I would add that the way you posed it, it sounds almost like a zero-sum kind of game. And this isn't, it's not a court of law. Mm-hmm. It's not arbitration. We're really here to help everyone make sure that the patient's rights are protected, and that we're really trying to serve the patient's interests from that patient's perspective. Mm-hmm. So however that patient has expressed how he or she wants to be treated, either through advanced directives or through surrogate decision makers, we want to make sure that that is being preserved and protected. So hopefully no one thinks of ethics consultations as kind of a zero-sum game, that one party wins and the other party loses, but really hopefully everyone gets together and resolves this issue, maybe not in a, satisfying, I don't know if that's the best way to put it, but in an ethically appropriate way, because oftentimes these end in someone's passing. And so the hope is that, we go through the process and everyone feels that this was done in an appropriate way, despite however it ends up.
Yeah, as we think about this specifically in the Catholic context, I'm reminded that we also, in this kind of context, we have to live with these decisions that are made, and these children are going to have to live with the decision that's made. And our goal here is obviously the protection and valuing of the dignity of this patient's life as best we possibly can given these circumstances, and trying to make a determination in this instance more than likely that could result in living or dying. And that's our primary responsibility, but there's also these children that are going to leave there. And that's always on the back of my mind as we think about how we handle these kinds of situations. So it's important, I think, that we attend to the fact that once this decision is made and we leave the room and we return to our offices, those family members go on to live lives that are going to be affected by our conversations and the decisions that happen in that room.
Well, that's kind of interesting, and I'm curious whether you think that's something specific to the Catholic tradition, because when you think about most of the mainstream bioethics literature, really it's talking about patient rights, in fact, and so what the patient wants, and really we focus very much on that gold standard of the patient's wishes. Yet you're more or less indicating here that somehow the perspectives of the family members are legitimate. They should play some role in our thinking about how this case resolves. Is that right?
I think that is right, and you have to you have to adopt that sensibility, cognizant of what the law requires of us, of who's deemed an appropriate surrogate, of what we're allowed to do and not allowed to do legally by way of withdrawing life-sustaining technologies. Different states have different laws around these contexts. But I don't know if it's unique to Catholicism, but it certainly has a rich place in our tradition. I mean, we're relational creatures, right? So we are not just isolated monads. You're talking about a family here, a family that might be losing their mother. And I know that weighs on me and affects the way I approach these cases, that it requires a gentleness and a patience on our part to appreciate that these are decisions with long-running ramifications.
That's interesting too, and we always talk about what the patient would want, and yet I think really if we talked to the patient, if the patient could speak to us, they'd probably say, I'd like you to take into account a little bit how my family members feel, right? I mean, it really is, they say, not a zero-sum game, that we do think about our family's needs at that moment when we're ill as well.
Yeah.
Good. Another emailer has asked us, palliative care services are proliferating these days. More and more hospitals, fortunately, have them. And they're asking us, is a case like this really better handled by a palliative care service? I mean, or is it the province of an ethics consultation, or is it easy to sort out? What are your thoughts on that?
We often work hand in hand with our palliative care colleagues, and they are very skilled at having these challenging and sensitive, particularly end-of-life, not only end-of-life conversations and exploring a range of options for people. They're usually very skilled at addressing those types of issues, and as well as listening to the family members and the patient if they're able to speak for themselves. And so often they do go hand in hand. And sometimes, I mean, I've been in consultations where I've been asked by the palliative care service to come in because they know there's an extra layer, an extra level that we can provide of expertise, of insight into the ethical issues that are there. Certainly, I wouldn't say it's an either or. Many times they probably have multiple conversations with families that involve ethical issues, and they're perfectly able to navigate those. So that's where the consult nature of our work comes in. When people perceive that there is something additional, another layer is needed, or they've tried it and the conflict has still not been resolved, sometimes they will say, okay, let's bring the ethics folks in because they have, again, another layer of expertise to offer here.
Yeah, I would agree with you on that, Katie. I think that to the questioner's point, we get into gray area here as to whose domain this is, and my general impulse is to say whoever would like it can have it, and that teamwork helps here, right? I mean, we've talked about how many countless consults never reach our phone line because chaplains or social workers have resolved that conflict long before it would have come to us. So there are certainly within the context of healthcare these kinds of different players that can work in this role. And I think one of the key things for people who occupy our role in ethics consultation is to develop collaborative relationships of respect and trust with these other partners on these various teams so that you really can approach this as a team.
I was going to add, I think there's just a natural affinity between ethics consultation and palliative care. It's no accident that one of our palliative care physicians does ethics consultations at our hospital. And it's interesting because she's a highly experienced physician, and she will even report that earlier sense of kind of feeling of unease of doing an ethics consultation, because even though they're trained to help palliate patients' symptoms and pain and suffering, trying to resolve ethical dilemmas is not necessarily part and parcel of what palliative care physicians do. And yet they can hopefully at least start to broach the topic of end-of-life care decision-making, and hopefully will then have the experience of working with ethics consultants, as our colleague does. She'll will involve us. She'll even in a case that she's involved in. So I think that both palliative care medicine and ethics consultation has this kind of natural alliance, and hopefully will work more towards working together, and more so once more palliative care services come on board at various hospitals.
It looks like we have another question. This person's asking, do you write recommendations in the chart, in the medical record, They're saying that at their hospital, the consult service would like to, but they are getting a lot of resistance from the hospital attorney and some administration. What do you think about that?
Yeah, I would say that it's essential that you have to document your recommendations, and it just goes back to just good practice. I mean, if you're going to do ethics consultation, if you're going to be taken seriously by your colleagues, you're going to have to document what happened, if there was a formal family meeting, and if you're going to cite either relevant ethics authority, whether it's the ERDs or AMA Code of Medical Ethics, the literature, I think it's absolutely essential that that gets documented. I think that's just being that's good medical practice, and it should avert, hopefully, potential liability, because then you're being transparent to other healthcare team members, and it has the impact of educating everyone else on the team, because you'll often go into a record and try to get an understanding of what's going on with the patient, and sometimes I'll just kind of home in on the social worker's note, because that person will give a kind of detailed social history, and oftentimes I think a really good ethics consultant can play that same kind of role, where people who are kind of maybe confused about what's going on with the patient, if it's been a particularly complex or challenging case, they can look at our note and say, okay, there was this challenge, or there was this conflict, there was a family meeting, these things were discussed, and all these different kinds of options were considered. We arrived at this set of outcomes or recommendations, and that gets documented, and hopefully that will have a positive impact on the care of the patient.
Spoken like our attorney, faculty member. So I would completely agree with you, Kayhan. I think, to Kayhan's point, transparency is the big thing here. That documentation really does allow us. And the only other thing I'd add to Kayhan's comments is that there is a real virtue in concision, right? You want to be brief, and you don't want to be personal, in my opinion. Ethics consultation is oftentimes profoundly personal, but I don't want to, in a medical chart, go through blow by blow the argument that I just left after 90 minutes in a room. So what am I going to do? I'm going to do exactly what you said, Kayhan. I want to say, here's the ethical conflict. This meeting happened. We've arrived at this set of recommendations. Thank you very much. So that kind of adopting a mentality of get in, be professional, get out, I think is very smart within documentation for ethics consultation.
So both of you have suggested, though, then that writing a good chart note is a bit of a skill, that it's something that perhaps you have to practice and review as a team.
I think that's a very good idea.
Yeah, and I think we do that amongst ourselves anecdotally. Sometimes we talk to one another when we have a case or a particularly challenging case. We'll actually say, what do you think about this? Or here's what came in today. I just got the consult. So I think it's appropriate to do that on the other end too, and say, I'm looking for a way of capturing this conversation, which was very sensitive and often very personal, and you want to represent what happened without attributing too much to any individual, because that's the personal nature, as well as highlighting, here are the key issues that were decided on or not decided on, and then any recommendations.
And the virtue of our system, our EMR, is that there's already a built-in template, and that just makes it, to go back to John's point, it just makes it much more organized. So it already fills out certain text fields so that you have patient biographical information. Why was this consult requested? The narrative, what happened, so all of that is just kind of prompting, and then that makes every note, I think, very well organized and very consistent from chart to chart.
Mm-hmm. Very good, yeah. And then there is the level of review of the ethics committee as well, right?
That's right.
We take our cases to the ethics committee and typically have an anonymized, a scrubbed note in there so that they can see what we've written and we can get feedback on that as well.
Right.
Well, it looks like our questioners are getting a little impatient with us. One of them has actually asked that said we're killing them. What actually happened in this case? What was the outcome? Did you get a good result?
Well, we did. The son and the daughter were able to say we will wait the 5 days, even though the daughter, that wasn't her ideal choice for her mother based on what she knew about her mother, but she was willing to give the doctor, Dr. Murphy, and the son a few days to see whether her mother really started to improve significantly or not. But she said at the end of 5 days, that's it. I don't want her to continue in this state and have a long and very limited recovery. My mother wouldn't have wanted that. And the son agreed with that. He said, no, my mother wouldn't have wanted to live in that kind of a situation for a long time. So at the end of 5 days, she had not improved. And so they did stop the kind of aggressive interventions. And within a few days, she died.
Oh, thank you. You know, and I hear so many of the points that you made earlier about process and that result. I mean, as Kayhan was talking about the benefits and burdens of treatment, once the doctor spelled those out, the family could agree, yeah, we'll take a chance on those 5 days if we can get those benefits potentially. We'll put our mother through those burdens for those 5 days because we now understand what we're waiting for. But at the same time, you've negotiated a solution that alleviates the fear that they have, right? I mean, their main fear is probably that you're saying 5 days, but now we're on the treatment train, as it's sometimes called. At the end of 5 days, we're not going to then be able to stop aggressive care and move her to palliative care. We're going to end up at a rehab facility or a long-term vent facility. And you've alleviated that fear by negotiating with the physicians so everybody understands what's on that page. So you've come away at that point with a really nice solution, it sounds like. So good. Well, thank you. I want to thank our panelists. And I want to ask Dr. Hardt, given what you've said to us so eloquently about our mission and how ethics consultation fits with our mission, would you have a take-home point for us in that context from after this case discussion?
Sure, I can give it a shot at least. I would say that as you think about this case, there's a way in which it is a classic case in our world, right? The vast majority of our ethics consultation cases are end-of-life care decisions. And in this case, we wind up in that cluster of directives, if we're thinking about this from an ERD perspective, that we spend so much time in, with Directive 56 and 57 on ordinary and extraordinary care. But to go back to where we started, this isn't a case with a particularly difficult moral problem. This is a very human case in which we're dealing with the challenge of children in a disagreement initially, and then them needing to negotiate with their physician to come to some resolution. Not at all an uncommon scenario, I suspect, in many of our facilities, and one that I think calls upon us to think about what our tradition offers by way of our capacity for listening, for helping families to come to a place where they can feel good about a very difficult decision, at least as good as you can feel, and then to leave them with the sense that they have truly been cared for having come through our institution's doors. So I think that that's the best take-home that we can offer on a case like this, and I've hoped you felt the conversation helpful. Thank you.
Thank you. I want to start by just acknowledging that at the beginning of the broadcast today, we did have some network connection problems. And so we are going to make a archived version of this available to our viewers, and so that will be available on our website, and we apologize for those difficulties. But we want to close with this final segment with Dr. Parsi and myself talking about some of the very practical things that go on in ethics case consultation. Typically when we're working with people who are running a consult service at a community hospital, they have a number of obstacles they have to overcome. One of the ones I hear about all the time, Kayhan, is that they want to do a team model. You know, and what we're talking about in our case, we were talking about an individual model very often, where we go and do the consult as an individual and report back to the ethics committee. But they like to convene small teams typically. They often say, you know, they have a physician on the team or a nurse on the team, several people. But they get a call and they have a hard time getting the team together in a timely fashion. Any ideas you can share with them about that?
Yeah, I mean, that's obviously a major challenge, is trying to get everyone involved in the case at the same time, even as a small group model. So, you know, we're familiar with the different models. We have our lone consultant model, which is what we do here at Loyola. We have the small team model, and then we have the whole committee model. Even with a small team, there are going to be some logistical barriers. People have, you know, different obligations, different shifts, and so forth. Now, one solution is just kind of a technical solution, and this is actually a solution that one of my colleagues at UIC has done, which is she's created a secure online environment where people can actually discuss cases, and she can, you know, list a recent consult request and get the input of everyone else. And this does a couple of things. So we can't necessarily get everyone in together. One person may have to take the initial lead on the case, and so you get everyone involved on the case. But then that person will then post the information about the case, and get input from their colleagues. And in some ways, it's just a kind of an asynchronous version of what we do in real time between the individual consultants that work together at Loyola. And if I get a consult, if you get a consult, you may come to me, or you may come to someone else and say, oh, here's my experience with this consultation. Do you have any thoughts? And we kind of just play with it back and forth. This is a little bit more formalized in the sense that it's written. People can then post their comments and have kind of this asynchronous discussion, and it's secure. And that's the most important thing, is to make sure that the patient's privacy is preserved. So you don't want to do this in an email system, which is not a secure system. You want to do this in a secure online system. But that seems to have addressed at least some of the initial logistical barriers of getting different people involved in a case, especially if you're trying to get more than one or two people. If you're trying to get, say, 3 or 4 people together, that might be a relatively easy technical solution to this issue of logistical barrier.
I see. So it's sort of like a first responder. One person actually goes and responds in a timely fashion, right, so that the people asking for the consult don't feel that you call ethics, nobody ever shows up.
Yeah, obviously, right. I mean, I think a responsible ethics consultation team should respond in a timely manner. Now, we say within 24 hours, but I would say almost always we respond immediately, within an hour at the latest. And that, you're right, that then shows the team that we're taking our job seriously and we're taking this case seriously. And so in those scenarios, yes, one person should probably then be a first responder, investigate the case, find out what's going on, find out the facts of the case, confirm the facts with the team members, patient's family. And then if they want to include other people, they can go through some kind of secure environment and get the other consultants involved. And then if they need to call a family meeting, then everyone can sit at the table and have that discussion. So I think that first responder system, along with some of these kind of technical solutions, can hopefully help in that kind of scenario.
Sure. In raising the technical solution issue, I'm curious, as we talked about the family meetings that we just heard in the previous case, and how some people are able to make it and some not. Do you see potential for using things like video conferencing over our computers or things like that? I mean, that's becoming more common.
Yeah, I think the technology has really improved. I mean, since we started at Loyola 10 or 12 years ago, video technology has improved tremendously. I mean, Skype has improved over the last several years. We use Adobe Connect in our online courses. I think this could play a really useful role in helping facilitate ethics consultation. We're working with a colleague who hopefully will be doing consultations at a long-term care facility and will facilitate students and others to participate in these consultations. So I think, this technology can play a really important role in allowing people to do kind of remote consultations, especially when you're not in an acute care setting. I mean, we're focused on the acute care setting, the hospital setting. That's where almost all of our consults unfold. But if we go beyond that and look at all the other potential settings, such as nursing homes, long-term care facilities, and so forth, I think that kind of video conferencing technology can play a really important role in connecting people.
Yeah, and we're finding it as educators very important, because there just aren't all that many ethics consults to train people with.
Yeah.
That's not typically a very high volume service, and so
Right.
if we really do want to train people to do ethics consults, have a next generation of consultants, we do have to make some accommodation to try to in some way get them in the room with us, in quotes, through technological
Right,
solutions.
and I think, again, as long as you address certain ethical issues such as consent of the family members, people involved in the case, I think as long as those concerns are addressed adequately through signed consent forms and things like that, then I think you can really facilitate conferences that don't just focus on the people necessarily in the room, but it can include other people, other experts, other people in training that are not there, right there in the same room.
Right, good. To change the subject a little bit, John Hardt talked a little bit about when the call comes in, how he has to kind of gather himself because they still, ethics consultations, when they call, they sound a little daunting. Would you mind talking a little bit about that fear element? I think, because I think a lot of people who start into this field assume that people who've been at it a while are see no problem. We just go and do it.
Yeah.
But it's not really like that, is it?
No, I think that fear, anxiety comes from a couple places. One, as I mentioned earlier, the team doesn't know us very well, and certainly the patient doesn't know us at all. So we're a stranger on some level. So that initial fear and anxiety comes from the fact that we wonder, well, what difference can we make? Even though we may be highly skilled at this consultant, we may have done this for years, that initial anxiety is, well, what can we do really that's going to shift the tenor of the discussion so that it'll resolve whatever conflict has emerged? So I think that's one source of the anxiety. Another source, I think, is just the fear of the unknown, not knowing what will happen. Will we make things better? And this is not necessarily just tied to ethics consultants who aren't clinicians. I mean, as I mentioned earlier, one of our palliative care physicians, when she's called to do ethics consultation, she feels that anxiety too, because no one likes, physicians don't like it, nurses don't. They wouldn't call ethics consultations if they were particularly skilled at doing this in the first place. So I think that kind of fear of the unknown, fear of conflict. Most people typically don't enjoy conflict. They don't enjoy dealing with particularly sensitive issues. And so I think that's where some of that comes from. I think some of that can be allayed by doing more of these and getting more expert and more comfortable at doing these. I think your skills can be enhanced by doing certain kinds of courses. I think certainly processing with colleagues. As we do informally with one another, and then formally when we meet as an ethics committee, where we do this kind of retrospective review and we look back on consultations that have occurred in the previous few months and kind of reflect. It's a form of, we don't call it that, but I think it's a form of self-reflection, to kind of ask ourselves and ask each other, how would you have handled that? Would you have handled differently? Maybe changing the facts. Hypothetically, what would you have done in this set of facts? And then that forces us to kind of reflect in a very meaningful way, so that hopefully then when we do the next ethics consultation, some of that anxiety may be a little bit alleviated. It may not completely eliminated, but a little bit alleviated, so that we feel like what we're doing has value and can really make a difference in the care of the patient.
Yeah, you said a number of very interesting things there. The pressure to try to do something to resolve the case. Like in the one we just heard, the physician often does say to us, well, we've already talked to the family, what are you going to do? And so we have that problem of thinking, what do I actually do? And to a large degree, we have to learn to believe in process. The process actually does accomplish something if we rely on it.
That's right. So I think, the focus of a lot of ethics consultation, skill development, the core competencies that the ASBH has put out, this recent task force update that was published in the American Journal of Bioethics, all these documents really focus on process, interpersonal skills, process skills, knowledge skills, assessment skills. So, we presume that we have some of these knowledge skills just because of the nature of what we do. Some ethics consultants may not have those knowledge skills because they haven't taken a course in clinical bioethics. Maybe they've taken an intensive week course, something like that. But those kind of softer skills, those interpersonal skills, and those consensus building skills, I think those are harder to acquire. They require a little bit of emotional intelligence, a little bit of practice, and but as you said, kind of trusting that process oftentimes will make a difference.
And so you alluded to the core competencies for ethics consultation that are outlined by the ASBH, and I would suggest to our viewers that if you're not familiar with them, I'm going to asbh.org and clicking on publications, you'll come across the opportunity to order the core competencies. It outlines, as you say, both knowledge skills, process skills, interpersonal skills. And so with the interpersonal skills, then one just has to practice in some way, I guess, right? Either live or role-playing.
That's right. I think you're going to have to do it either in a kind of an apprenticeship model. You work with someone who is a more experienced mentor in ethics consultation, or you do it in some kind of simulation. Like we have a hybrid summer course where we take our students and we put them through a series of simulations, and you get feedback, and a number of other programs out there have these kinds of courses where students are taken through a series of simulations so that they get a sense of what it's like to play the role of the ethics consultant. They get immediate feedback, they get video feedback, and then it also, again, offers them that opportunity for self-reflection, kind of then think about what would I have done differently, what did I do well, what did I do not so well. So, yes, I think that kind of doing those kind of simulations and then just kind of practice it really is a tremendous benefit. But again, like you said earlier, the challenge is trying to get it because this is not a high volume activity. This is not like a busy psychiatry service that may get hundreds of consultations in a given week or a given month.
Exactly. Okay. And so as you say, that one can take a course on simulation and play out an ethics consultation with actors playing the roles. But also on our website, because we understand not everybody can take an ethics simulation course, we do have materials there in which you see videos and can critique people. We have the scripts so you can actually role play the cases with your committee and practice and get feedback from each other. So we talked a little bit about the process and interpersonal skills and knowledge. I mean, where does one get the knowledge? I mean, because there's a lot of framework being tossed around today in that analysis.
I mean, bioethics, as you know, it's just grown in the last 40 years from being a very small, modest little discipline to this really flourishing field, and a big part of it is clinical bioethics. So there's a lot of opportunities to get more expert. I mean, there's websites such as bioethics.net, there's journals such as AJOP and the Hastings Center. There's a journal of clinical ethics that focus specifically on clinical ethics. There's now a plethora of degree programs, ours, and Albany and Creighton and a number of other places, MCW, that have formal degree programs that help people kind of cultivate these knowledge skills in a very formalized way. There's fellowships. The University of Chicago has probably the longest standing ethics fellowship program around, where historically physicians, but now other professionals have gone through to develop their ethics consult skills. So there's really a variety of ways that people can cultivate these specifically ethics consultation skills and knowledge, and to get that kind of broader base beyond just ethics consultation. If you want to learn about clinical bioethics beyond ethics consultation, or research ethics, or theories of bioethics, or Catholic bioethics. So there's a whole range of different areas for a person to explore and to get expert on beyond just ethics consultation.
Excellent, thank you. Well, it sounds like we really came to a few conclusions here in our discussion today. And sort of to summarize for our viewers, it sounds like one has to work out just the logistical things, the obstacles in their institution, and arrive at a consistent process so they know how to proceed. It sounds also like then we want to develop our own core competencies, our own skills, and we do that in a variety of ways. And again, we've created a button on our website, so if you come to bioethics.luc.edu and click on the button at the bottom that says Develop Your Ethics Consultation Skills, we have a variety of materials there for people to help practice. And once one has gotten the policies and procedures down, developed your skills, to develop a supportive environment, develop an environment with colleagues so that you do walk each other through this, you do support each other through this. And I know for us, it's among the things that's made us closest as a team, is actually working together as ethics consultants and supporting each other through difficult situations like the one we heard today.
No, absolutely.
So I want to thank my colleagues, Dr. Hardt, Dr. Katie Wasson, Kayhan, and thank you all for your time today. And again, please come to our website at bioethics.luc.edu, and we hope to see you in future broadcasts like this one. Thank you so much.